gentlemen, we start off the free paper session. I'm sure all of you are so eloquent speakers that timing is going to be an important modality. So I would request you to please stick to time. You are running on a very tight schedule. So it's 8 minutes and 2 minutes for discussion. I'll hand the speaker the mic over.
Can we start with the first speaker? Dr. P. Panda from Railway Hospital, Kota. Different modalities of treatment of ganglia and comparison of their outcome. Dr. Panda.
Respected chairperson and all the delegates in the house. My topic is different modalities of treatment of ganglion and comparison of their outcome. Though ganglion is a very common problem among the surgeons, but it gives worries to surgeon also, because due to its complication, most common complication, that is recurrence. Recurrence is a very common complication in ganglion. That's why it is important to discuss. Ganglion, also known as Bible bump, because in ancient times people use as a treatment also hit the Bible, the heavy Bible on the ganglion. That's why it burst. Also known as Giddens disease. Giddens published Bible, that's why it is Giddens disease, and also known as mucus cyst. The epidemiology being female are more affected than male, it is 3:1 ratio, and the age between 20 to 60 years. Site being, the wrist is the commonest site. When it is present in the back, it is known as dorsal wrist ganglion. When it is present in the front, it is known as volar wrist ganglion. The Stafford lunate joint is the commonest site, the commonest place, also present in back and finger. There are many etiology, but the outpouching of synovium is one of them. Also, as a degeneration of connective tissue and cystic space formation and the production of mucin by fibroblasts is another etiology. But the most common accepted one is due to the check valve mechanism of the joint, which allows the fluid out of the joint, but the fluid cannot go back due to check valve mechanism. Mostly they present asymptomatically. Only the presentation is the swelling. Patient comes due to cosmetic purpose only. At times there may be limitation of activity, and pain is the last complaint. It is compressible, it is movable, it is also transillumination positive in fair persons, as we seen in the photograph. There may be sensory or motor nerve palsy due to compression of cutaneous branch of the median nerve. The main thing is the treatment. One is conservative, one is surgical intervention. When people are satisfied with your consultation, then you can wait and watch. Also, as I mentioned earlier, it is a Bible treatment, but it is not so recommended. The surgical intervention being these are the procedures available. Aspiration, this is an OPD procedure. Aspiration, retention of non-absorbable suture for 3 weeks. Aspiration with injection of steroid for multiple sittings. Open surgery and arthroscopy. Indication of surgery being, one is cosmetic. If there is pain, you must go for surgery. Limitation of activity, and if at all, features of nerve involvement. We have taken the cases from October 2007 and between October 2007 and 2009. All the cases operated in our hospital for ganglion. Age group, it is between, in our study it is 17 to 52, and the mean age group is 36. male, out of 18 patients, 13 are female and 5 are male. The procedures we have done, 12 patients undergone aspiration with retention of non-absorbable suture for 3 weeks, out of which 5 recurrences are there. Aspiration plus steroid injection undergone 4 patients, out of which 2 having recurrence. Only aspiration 1 patient, 100% recurrence. Open surgery 1, there is no recurrence. Total 18, out of which 8 have recurrence. The main thing to see here, all the procedures have similar amount of recurrence is there. Since aspiration is very only 1 case is there, so it is early to say it is 100% recurrence. What we see in the literature, it is mostly 40 to 50% recurrence is there. This point to be noted for discussion on the later. This is a case of steroid injection and very good result is there. One thing to note here, the steroid must be of low concentration. If it will be high concentration, there must be white patches after 2 to 3 weeks. Discussion, as literature says, it is between 20 to 60 years. In our group, it is 17 to 52 years, which matches the literature. Female 13 to 15 also, female are having higher recurrence, higher incidence than male. Recurrence is minimal in open surgery. Literature says, also our experience says open surgery, but we have undergone only 1 open surgery. I will tell why we have not preferred open surgery. Because open surgery has some disadvantage also. It has also recurrence of 40 to 50%. And there is the trauma of patient come for cosmetic purpose, and the scar will be repeated one, which will not fulfill the satisfaction of the patient. That's why we have not done open surgery frequently. But recurrence is nearly similar in also aspiration and retention of the absorbable suture or steroid injection. With non-absorbable, nowadays arthroscopy is the best choice, but in all centers arthroscopy is not available. With the non-availability of arthroscope, open surgery is the best treatment done under GA or regional block. Local open surgery is very difficult to do. Recurrence is almost equal in all procedures and require multiple sittings. Looking into scar, a cosmetic, open surgery, and the requirement of anesthesia, aspiration with steroid injection or retention of non-absorbable suture is the best treatment. Here is a
You have another 1 minute.
Sir. Here is a case of aspiration. We know we do aspiration every time, but the main thing what I want to show is how we introduce the non-absorbable suture. After aspiration, you pierce the needle through and through and put a non-absorbable suture from tip. After that, you remove the needle and the suture will be inside the ganglion itself. And then tie it, keep it, give a dressing pad and keep it for 3 weeks at least. What we did, we remove it on the 7th day. This is a faulty technique. Thank you.
Thank you. The time is up. Thank you. We have 2 minutes for questions. Questions from the floor.